Talk by Dr. Kumaran. He'll be talking to us about a few cases he managed in his eye center. So, a few case studies. Over to you, Dr. Kumaran.
Good afternoon and a warm welcome to one and all. When you face an emergency, but as you know, there's always some teething problems when you face an emergency. Things don't go the right way as you have planned it on your paper. So we, as a field in ophthalmology, do deal with significant number of geriatric patients, but we have difficulty in dealing with these patients because emergencies we don't see them regularly. Most of the eye care centers in India are still run by a single or a couple of doctors. As we are not dealing with emergencies, it becomes difficult for us, and we do not tell the difficulties our staffs are going to face. So it's very important to have a dedicated code blue team in your hospital, however small or big they may be. So I'm now into my 17th or 18th year of my practice. The first 7 years I didn't have a code blue team, and I was very lucky that I didn't have to face any situation. But once I formed the code blue team, an emergency situation happened, and I'm going to share to you my story of what I did and how you can learn from my mistakes I went about. So this was way back in 2017. We had a 64-year-old lady posted for the second eye surgery, reported to the hospital reception. She was shifted to the OT after initial assessment, all vitals normal. And at 10:30 a.m., she wanted to use the restroom. She came out. After that, she fainted outside the OT complex, became breathless, and collapsed. I was not in the scene because I was operating on another patient. So the code blue was activated and the patient was shifted into the OT. So we really didn't know what went wrong. We have done all the investigation for the first eye surgery. Everything was normal, but we really didn't know what to do. So we did a retrospective analysis to see what happened. This lady had actually walked in one evening in a busy OPD. She presented to us from the nearby 30, 40 kilometers from Chennai. She underwent all the investigation. She was found to have a bilateral cataract. All necessary ocular and systemic investigations were done. We do have the histology test. And because everything was normal, I did look into her medications, hypertensive and anti-diabetic, everything was normal. She went and underwent side effects for surgery. She reported to us for the findings. Everything was normal. And we fixed her second eye surgery. So what really went wrong? So on the day, she was shifted to the OT. Auscultation showed rales and bronchi. Her BP was sky high, and oxygen saturation dropped. She was started on Lasix and nitroglycerin, and we did have an MOU with a nearby hospital. So with minimum delay, the ambulance arrived. And with the theater notes from the anesthetist, I was not able to accompany because I was already doing a surgery. One of our stars accompanied the patient. The patient was received in the ICU nearby. It's very important to have an MOU because sometimes you will not have beds in the nearby MCU hospital. Artery ventilation started, everything went on well, but suddenly at 12:45, she had a ventricular rupture and we had to lose the patient. So what really went wrong with us? This patient was an obese patient. I had actually looked into a medication, but did not look into a prescription. This particular lady had actually skipped two of the medications which a doctor has prescribed. The son came up with the prescription later. The ECG, serology, and blood were normal. We got carried away, and the first eye surgery was uneventful. So when we admitted the patient after 7 days, we did not reevaluate her, which is very important whenever you do a surgery for high-risk people. So we had difficulty in deciding on what was the problem because we didn't have any history. She was an obese patient. She had difficulty in finding an IV line because we don't start IV lines for all our patients. And very difficult to say who is high risk or not. And there was panic all around. The first time we are facing a code blue situation. The other thing is that we didn't have adequate staff to shift this obese patient into the stretcher. That is very, very important. So unfortunately, the CCTV camera was not functioning. We don't know why it didn't function. We had not recorded the events. The only fortunate thing was everything happened in front of the son. So he was actually seeing what we were doing, and that was the only console which could have, which saved us from other legal situation. Imagine if this has happened inside the theater where the staff and the other people are not allowed, it could have been really difficult. So how do you prevent all this? Have a high degree of suspicion, follow protocols for readmission, have an IV line for all high-risk patients, Check all your emergency medicines, gases, and instruments before you start your OT. Have a dedicated person not only check your ophthalmic instruments, make sure all your emergency equipments are in place, assign a staff separately for this, and have an emergency of a minimum 6 people. So finally, have another physician or at least an anesthetist to monitor your patient so that you can perform your surgery well while he does this. So these are the other common emergencies we come across. Hypoglycemia is a very common setting which Dr. Nirmal has clearly described to you about. And seizures is something we have not discussed previously. The main aim of seizure is to protect our patients from trauma, prevent aspiration, and prevent further seizures. This is something we come across in ophthalmic practice quite common, the vasovagal syncope. Some of the reasons are severe anxiety, fear, stress, and acute anaphylactic reaction can also precipitate a vasovagal attack. The major pathophysiology is sudden parasympathetic response or any action which is going to decrease the sympathetic activity or any factor that reduces the venous return to the heart. So how can you prevent a vasovagal attack? Always have an awareness, a careful history taking, preoperative evaluation, ask the patient about the head tilt test because some patients do complain of syncopal attacks previously. Intraoperatively, especially during squint surgeries, make sure you manipulate your ocular tissues very gently and have a support staff or a standby anesthetist whenever it is needed. The main treatments are CPR, intravenous epinephrine, rapid rehydration with NS, and the Trendelenburg position. So in summary, have a code blue team with minimum 6 persons. Remember to record the events. Ensure all your emergency medications and medicines are in place. Checklist them on a daily basis. Please have an MOU with a BLS or ALS ambulance and with the ICU providing hospital, multi-specialty is nearby. A standby anesthetist or a physician for all high-risk cases. And as Dr. Jayantan has said, frequent training, mock drills. Finally, have everything in place and pray to the Almighty that nothing eventful happens. Thank you.